This case is a locally advanced, non-metastatic and an elderly frail patient. It's an 86-year-old gentleman with a history of atrial fibrillation on Pradaxa, AS, chronic kidney disease, comes in with hematuria for 3 days. He was admitted locally to a hospital. CT scan showed a bladder tumor, which I think I can show you on the next slide. And a Foley catheter was placed. It was started on continuous bladder irrigation. It was transferred to Thomas Jefferson. Cardiologist felt that he was stable for general anesthesia. He underwent a TURBT with bilateral stents, and then he had a post-obstructive diuresis. And the biopsy at TURBT revealed an extensive high-grade papillary carcinoma with neuroendocrine features and abundant necrosis. There was invasion of the lamina propria and muscularis propria, as well as vascular invasion. And this is his CT scan. So you can see this very extensive mass in the bladder. Further workup, CT of the chest shows some patchy opacification in the upper lobe, thought to be pneumonia. He had two nodules in the upper lobe, concerning but not clearly definite metastases. He also had bilateral pleural effusions, but as you know, he had renal failure and a lot of fluid balance problems as well. A bone scan showed no evidence of metastatic disease. So the questions that this patient raised were, what are the treatment options for this patient? He's frail, he's got comorbidities. So if he was transferred to Yale, Dan, what would be your approach to a patient like this?
Well, a couple of things. Firstly, I'd want to biopsy the lung nodules to find out whether they were truly cancer or not. If they are metastatic disease, then clearly this patient should have PD-L1 staining. He's not platinum. He's a frail individual who probably would not do well with cisplatin-based chemotherapy, even though his creatinine is 1.2. So you could, say he's an ECOG of 2 and say that he's platinum ineligible from that standpoint. So I'd want to know what his PD-L1 staining is at this time. If he's PD-L1 negative, he should not get checkpoint as primary therapy. I would go with chemotherapy. Again, whether he really should get cisplatin, I think I'd really have to see him at this point. He's got this neuroendocrine component as well. I'd like to further characterize that. Is that predominantly neuroendocrine? Is this neuroendocrine differentiation? What percent is urothelial carcinoma? We've actually, in the worst case scenario, it's a pure small cell, which will respond to MVAC. In fact, we published that a number of years ago, but probably is better treated with platinum and etoposide. So those are the things I'd be thinking about with this patient.
Any thoughts from
similarly, extrapulmonary small cell is a bad disease. The prognosis is really poor. And as Dr. Petrolak says, platinum does have response. If you can't get cisplatin, you could try carboplatin. I'm not really sure of the value of radiotherapy to the bladder. That's the second question. The tumor is quite big and bulky. So if he was bleeding, if he had, for palliation, yes, but I don't think you're going to be able to definitively treat this locally. There are, clinical trials for small cell cancer, either looking at PD-1 agents, looking at other sort of antibody drug conjugates, so I might think about that as well. But I completely agree, like getting a better understanding of, is this just a couple neuroendocrine cells in there, or is the whole thing just a big, sort of extrapulmonary small cell? That really changes the management.
One thing which sort of non-standard, if you really wanted to be a sneak and try to get more bang for your buck, you may want to radiate the bladder also at the same time that you're giving checkpoint to potentially get an abscopal effect. I haven't really seen it in bladder cancer, but people have seen it in melanoma, and I think that and SWOG right now, we are planning a trial for those patients who don't want to undergo cystectomy to give atezolizumab as well as radiation therapy. So, I mean, that certainly could be something you consider. It's not standard, but it's something that in this individual case may be the way to go.
Would you give, the second question here was, if you were going to radiate the bladder, would you give concurrent chemo at all with it?
5-FU mitomycin, it's not a walk in the park, even though it's technically approved for platinum ineligible patients, or you're able to give it. So if you were definitively trying to cure him of bladder cancer, yes, you should give him concurrent chemotherapy. There's about a 15% absolute survival benefit for that. But if these are lung nodules and this is truly metastatic, I'm not sure I'd add the chemo at that point. It may be hard to tolerate, and I'm not really sure what bang you're going to get out of that. I don't know if you feel this.
Yeah, I don't think you're going to get much out of it in this situation. I mean, this patient has metastatic disease, and again, I think 5-FU and mitomycin are not really terribly active agents in this disease.
Okay, great. Any thoughts or questions from the audience on this case? Let me get a microphone to you. Hold on.
If I remember right, he's 86 years old, has a really poor performance. I don't know. To me, it's maybe the hospice.
That's a reasonable thing to think about. It really depends on his goals. The checkpoint inhibitors, there are small cell cancers that respond to these. And I've had patients who were in the ICU, unable to walk, unable to swallow because of, severe comorbidities, where the entire medical team said the patient should be in hospice, treated with a checkpoint inhibitor, and literally came into my clinic carrying her granddaughter. So, it's a very much a personalized discussion. But I think you're right. But like, just best supportive care, palliative care is really important.
I think what you bring up an extremely important point in terms of how much of a patient's performance status is due to their comorbidities and how much is due to the tumor. If you have somebody, and we've actually been discussing this in terms of platinum eligibility, if you have somebody who's predominantly having their poor performance status because their cancer is causing it, then I think it's appropriate to go ahead and have a good discussion with the patient about what the goals of therapy are. If this is due to cardiac dysfunction, if they have an EF of 16%, I think your answer, it's totally appropriate not to consider treatment. So I think you're bringing up a really, really important point. You've got to be a good physician and understand your patient.
Building on that to some extent, I wanted PD-L1 test.
Right.
Your discussion. Since the at my practice, I think it's pretty infrequent that I see a patient who's cisplatin eligible that could potentially tolerate carbogemla, just like this. Is it worth skipping over PD-L1 testing in that context?
It's I think the whole field of bladder cancer bladder oncology is really perplexed by this, because every trial, Dr. Petrolak showed you about 7 different clinical trials. 6 of them showed no real value to the biomarker. And then this FDA alert came out 2 months ago, and I think we're all still scratching our heads. So if you go by the alert, you should be testing these patients. That said, you're right. If there's no other option to treat this patient, then I'm not sure the biomarker necessarily matters. Right. The reason the FDA issued that alert was to say if the patient can get chemo, they should get chemo in place of PD-L1 if they're biomarker low.
There are so many problems with those marker studies. Inconsistent, this is from archival tissue. They could have had any number of treatments beforehand. We know that PD-L1 is an acute phase reactant. It could be organ specific. You have different levels of expression within an individual biopsy specimen. So I'm not surprised. I'm actually surprised that we actually saw any positive correlation more than anything else. And I think we need just simply better ways of understanding who's going to respond, who's not going to respond. I think that really the trick is going to be with imaging, not necessarily with individual path biopsies. Sure. Oh, absolutely. In fact, there are some clinical trials where I've become extremely frustrated. I've seen patients progressing in front of me while we're waiting for these tests to come back. So, there are 2 ways we can do it. We actually put out an alert that there should be a discussion with all of our patients regarding what the level of PD-L1 expression is. If they're on PD-L1s already in their first line, we're now doing the testing at the same time, and then we're counseling the patients as to what they want to do. If they are platinum eligible or if they're second line, we don't bother doing the testing. So I think that it really, it's only focusing on this group of patients. I try to also assess how sick they are, as you're saying. If they've got liver mets, that's something I'm probably going to want to go with chemotherapy first anyway at that particular point. So it's really, I think, really you have to have a good complex discussion with your patient.
Yeah, I would second that. As much as I'm excited about immunotherapy in bladder cancer and across oncology, chemotherapy does have activity in this disease. There are patients who have complete responses to chemotherapy, sometimes durable. And so I feel like this sort of pendulum has really swung in favor of immunotherapy. But if you really do see a very sick patient in front of you and you know they're PD-L1 low, then clearly they should get chemo. But it's a very tough decision. We have not completely formalized our pathway there. We order it, but it's not. I don't think we have a consistent guideline, and that's something we need to do.
Just a quick question, Dan. You alluded to this in your introduction about BCG. Are there any trials of checkpoint inhibitors in non-invasive bladder cancer?
Yeah, yes, in SWOG, we're doing one with atezolizumab in those patients who fail BCG. There are other trials with pembrolizumab. Every checkpoint, I believe, is being evaluated in this particular setting. So it's going to be interesting because the mechanism is different. BCG is more direct cellular attachment, and it's really not unclear what the exact mechanism is after that, but it does cause more immunogenicity. This, of course, is looking at PD-L1, so I'll be very, very interested to see whether this is going to be positive or not.
Does non-invasive have a high mutational burden?
I'm sorry, does non-invasive? That's a good question. We've actually looked at PD-L1 status in our bank with non-invasives. We have found is that it doesn't seem to correlate with BCG exposure. It seems to correlate with the number of TURBTs, which may be related to inflammation. But there is expression of PD-L1. I couldn't give you a good answer as to whether the mutational status is any different. We do know that FGFR3 is expressed in a higher rate of these particular tumors. But biologically, I'm not sure if you're aware of
Yeah, I don't know if there's the mutational load. But there's definitely genetic changes that occur between non-muscle invasive and muscle invasive tumors. RB loss, P53, things like that. So there is a different profile, and we'll see. These studies are underway. We'll have data in the next maybe two or 3 years.
Exactly.
So let's go on to the second case by Dr. Vogel from New York. I think many of you know Steve from his comments usually at the national meetings, and he's usually very right on with his comments. So again, there's going to be a common theme here somewhat. So this is an 81-year-old gentleman, presents to the hospital with hematuria and voiding problems. His creatinine was 7, but with hydration, etc., it came down to 1.8. He was anemic and required transfusions. Initially, in addition to the hematuria, he was thought to possibly have a GI bleed. I guess an ultrasound showed that he had a markedly distended bladder. He was in retention. When he presented, he had bilateral hydro. In addition, he had some renal calculi and a large prostate. There's no evidence of bone or liver metastases. An MRI showed a left bladder wall mass at the UV ureterovesical junction. The mass was large, 6 by 2.6 centimeters. Urologist tried to obtain tissue twice, but failed. He had a history of medical problems, hypertension, lipidemia, etc., and a history of stones. He also had orchiectomy for testicular cancer in 1998. So I guess he was then discharged and showed up in Dr. Vogel's office in February of this year. His performance status was almost 3, I guess. He had massive edema and just got out of a nursing home where he was sent after his hospitalization. Creatinine was 2. PET scan now shows 2 liver metastases, some adenopathy that was FDG active, and he had renal calculi, and he had a non-functioning right kidney. So pretty advanced disease. So Dr. Vogel's question was sort of similar to this last patient. What can you possibly do for this patient?
Yeah, I mean, he's pretty sick. He's basically dying of bladder cancer, especially with liver mets. We know that liver metastases in this disease portend a very poor prognosis. Median survival is usually less than a year. And with, he has multiple organ systems down now, right, between his kidneys. His performance status is bad. He's someone where, going back to our question about PD-L1, I'm not sure I'd bother testing because this patient can't get chemotherapy. He can barely walk. So you could offer him a trial PD-1 like this patient I brought up just before. Every now and then you see these really amazing, dramatic sort of comebacks. But we know response rates to PD-1, PD-L1 inhibitors are lower in patients with liver metastases. So I wouldn't expect too much, and it goes back to a kind of goals of care discussion with him.
Yeah, so what actually happened, Dr. Vogel offered him Atezo, and he received 4 doses. Had a recurrent hematuria requiring transfusions. He did not experience any significant toxicity, and his CA19-9, I guess, that was being used as a tumor marker, rose from normal to about 200, got symptomatically weaker. PET scan showed progressive metastatic disease. When Steve presented this case, he was particularly frustrated with the situation because he was facing a dying patient, and the family refused to accept that, refused to accept hospice, and they brought him to the ER. He was transfused and then died the next day. So I think, Dr. Vogel's thoughts were the same as yours.
Yeah, this is very hard, and this gets more into the art of medicine about how to counsel patients at the end of life. Should we be offering checkpoint inhibitors to these patients when they're this sick?
Maybe I shouldn't bring this up, but it does raise a question of all this television advertising that you see from a variety of cancer centers, promising, precise, personalized therapy for your cancer.
Right.
And I think it sometimes gives families unrealistic expectations.
Well, it's a double-edged sword, because I think that there is, unfortunately, sometimes a lack of awareness, and some people don't have the access that we do to all these new treatments, and they may not hear about it. So I think from that standpoint, it's good. I think from the other standpoint, that patients feel as if, that the doctor has the answer, that they have something that they're not giving to them, or that they wanted to force a situation where they use a drug that's not appropriate for a different clinical indication. I think that that's where it creates false hope. We're very, very fortunate in our profession that we know where to send patients, even outside our own field. And the general American public is not that, for most people, they're not that fortunate. They really only deal with health issues when they arise.
No, I'll say that.
It's interesting. I might ask Tom Beer, sitting up here, because I just moved to Oregon about 3 years ago, but he's been there a long time. And Oregon has the death and dying, has physician-assisted suicide available. I have not had to face that with my patients. I just wonder what your experience has been.
So, in practice, 19 years, and I've not had a patient take advantage of the act yet. It's pretty rare. I've had maybe a dozen patients over the years inquire about it seriously. Make the formal request. Mm-hmm. I refer them to Chuck Blanke, who at our institution has come forward to be the lead doc on that front. But for all of my patients so far, it's been really more of a source of psychological comfort for them that they have an option in case things get out of control. I think it's there's a fear that pain will be uncontrolled, life will be miserable and so forth, and not worth living. Thankfully, almost always we're able to address those kinds of issues successfully. Yeah. So it's been a non-issue really in my practice.
Yeah, like I said, I've only been there a few years and I've not encountered it, but I think you're right. I think it does speak to the fact that I think with current hospice care, we are able to keep our patients comfortable.
You mentioned that
Yeah.
I think this is one of the real dilemmas I face is with elderly or with poor functioning patients, where there's an opportunity to treat with checkpoint, with checkpoint inhibitors. We know that there's a possibility, albeit small, that you might have a really good response, and yet most won't. And if you present that, because that's fair and reasonable, it's very hard for a patient to kind of walk away from that opportunity. And I worry that we're overtreating for that very reason, because we lack the ability to better discern which patient will respond.
Yeah, I completely agree. I mean, when I start any checkpoint inhibitor with a patient, not just the very sick ones, I tell them, only about 1 in 5 people are going to respond to this. And sometimes I tell them, if you were going to Las Vegas and you were betting on this, you would not bet on having a response. And sometimes that helps them kind of click, like, oh, wait, this really is unlikely to work. There was an op-ed in the New York Times about 2 months ago by our chair of the Department of Medicine at UC, Bob Wachter, talking about this exact issue of how the availability of these drugs at the end of life is really making that discussion about end-of-life care so much more challenging and complex. And it was sort of a call to be able to sort of fund palliative measures as well as treatment measures at the same time. And obviously costs spiral out of control, but it offers sort of opportunity or possibilities to the patients. But it's a major challenge I think we're all facing.
I did want to ask you one question about the case you presented. The patient came in with basically almost grade 3, but grade 2 diarrhea, and you did an immediate colonoscopy. I think in our situation, I've seen, we've usually started those patients, if we exclude C. diff and other enteric pathogens, we've usually started these patients on steroids, and if they don't respond, then go on a colonoscopy. What do you think?
I think it depends on the degree of diarrhea. And also the frailty of the patient, making sure you know what's going, your confidence in the side effect. I don't know if you.
Yeah, I mean, I agree with that. I think that you just have to assess your patient and see what the overall clinical picture is. And I mean, steroids, you stop steroids. I mean, steroids have been shown not to have an effect on the outcome in these patients thus far. Mm-hmm. So, I mean, I think that they're a good alternative. And if you want to avoid the invasive procedure, it's good. It's a good thing.
Okay, so we have one more submitted case. This came from Michelle Boyer.
She's my fellow.
So this is also an elderly gentleman with multiple medical comorbidities, 71 years old, obesity, osteoarthritis, hypertension, presented to the ER again, similar to the other cases with gross hematuria, unable to void. A CT of the abdomen showed an atrophic left kidney, a hypertrophied right kidney, so this atrophy, the left kidney was probably chronic. No hydro, and had an irregular mass in the right posterior bladder measuring 3 by 2 centimeters, but no visible lymphadenopathy on the CT scan. Underwent a TURBT, which showed urothelial carcinoma, high-grade papillary solid with muscle invasion, but no lymphovascular invasion. So on his physical examination, I think here's a clue that his performance status is not great. He was examined in a wheelchair. He had 3+ edema. He was able to stand with effort. Creatinine was 1.4. Clearance was all right, 50 cc's. He was felt inoperable and was referred for concurrent chemoradiation. Started radiation with twice weekly gemcitabine, but his creatinine went up. And a repeat ultrasound now shows a right hydro. Remember, he had a non-functioning left kidney, and now he's got hydro on the right side. Creatinine went up. He had a right percutaneous nephrostomy placed to bring the creatinine back to normal, and he completed his radiation and gemcitabine. Following the treatment imaging revealed the bladder mass to have shrunk by about 50%, and he had no evidence of metastatic disease. He underwent another TURBT, which revealed invasive high-grade urothelial carcinoma, again with muscle invasion. He did go PD-L1 tested, and it was 2%. Creatinine is 1.1. They considered a salvage cystectomy, but because of his medical comorbidities, he was felt to be at too high a risk. So what would you do at this point? Would you offer him any sort of, quote, adjuvant therapy, systemic therapy, or would you just observe this patient and monitor him?
I mean, one thing to be sure of when you're biopsying patients after radiation is that it's actually real sort of living cancer, and there's not a radiation effect. So that's not mentioned there. So I just would definitely talk with the pathologist, because you may still see residual tumor in the bladder 3 months later. You know, radiation outcomes are best in patients who have essentially small tumors, no hydronephrosis, no CIS. Patients who have CIS tend to have a much higher recurrence rate. So this is not the ideal candidate for chemoradiation. He was sort of given it by default, which is okay, I think. You get local control. But I wouldn't expect him to have had a complete response. Now, I guess, you know, he feels similar to some of the other patients. I'm not sure, would you wait to see progression, or would you just start treating?
The real issue is, you know, how measurable, how valuable is that lesion? I agree with you. I think you really need to know whether it's necrosis or necrotic tissue or a viable tumor. I have no problems waiting in a patient like this. He's poor performance status. You may want something measurable. He's got low, his PD-L1 was tested, I guess this was 2%. Yeah. It's weak. And he's got a chance of responding, but it's not great. I probably would wait until something popped up.
Wait, hold off for systemic.
Yep.
Yeah, I think so. I mean,
Yeah.
The other thing is this patient really only has local disease. So some of these patients, it's not a cure, but they can be managed with serial TURBT,
Exactly.
even partial cystectomy. Probably not this patient, but you know, as a palliative measure for very elderly or very frail patients, that's reasonable. But at the end of the day, this patient is very likely to you know, to have bladder cancer and to die of bladder cancer, one way or the other. So.
I was going to ask you about your lecture about the toxicities and whether in patients with prior autoimmune disease. What about MS? Patients with a history of multiple sclerosis, particularly sort of the slow indolent.
Yeah, you know, I'm not sure if that's been looked at.
I haven't seen. The reason I'm asking is this came up in discussion a couple weeks ago, and I'd never seen anything about it.
Yeah, I've not faced that issue. I have faced patients who've had organ transplant who then develop cancer, and that's I think really almost no data on that. So there are these sort of special cases where it's really hard to know how to manage that baseline comorbidity.
We actually had a case at Yale who had a patient who had metastatic renal and had a transplant, and we treated him. He was treated with checkpoint. And he responded. Response came first, and then the graft failed after that. So it's going to be a really tricky situation in those patients.
But you don't consider that absolute contraindication?
So the patient I'm actually in the process of treating now, we actually did a transplant nephrectomy. We removed the kidney because of this concern of graft failure. He was also on steroids and immune modulators, and so. I don't know if that's the right thing to do. You know, we're gonna publish that. We have 4 patients now with organ transplant cancer getting checkpoint inhibitors. I don't know if Dr. Paul or others have faced this issue in kidney, but it's just a huge challenge.
Yeah, I'd echo those comments. You know, Dan, I know we're kind of coming to the tail end of this session. I wanted to ask you about enfortumab. You know, it's a drug that you've really, you know, played a pivotal role in developing into the breakthrough designation. Can you tell us a little bit about that?
Sure. I would have loved to have fitted. It didn't fit into the talk, unfortunately. So enfortumab vedotin is a antibody drug conjugate. It's basically taking an antibody to nectin. Nectin is expressed in about 94% of bladder cancers, and it's linking it to MMAE. In our phase 1 experience, which we presented this year, updated this year at ASCO, we have really a very similar response rate in patients who've had prior checkpoint therapy versus those patients who haven't. It's about 40% overall. But what's really, I think, exciting about this drug is the pattern of response. About 40% of patients with hepatic metastases have had responses with enfortumab vedotin. The survival that was reported at ASCO this year was, I believe, about 13 months median. And again, predominantly these are patients who are checkpoint failures. So it was granted breakthrough status. The phase 2 trial was completed about a month and a half, 2 months ago. We're in the process of doing a confirmatory phase 3 trial at this point against standard of care chemotherapy. The interesting thing, back to the second patient, so we do have a phase 1/phase 2 trial of enfortumab vedotin combined with checkpoints for those patients who are not platinum eligible. And that patient, had he had a better performance status, would have been eligible for that particular trial. So that's what we're thinking of in terms of our first-line platinum ineligible patients. So it's an exciting drug. There are other drugs in this class as well that are being developed. IMU-132 is an antibody to TROP2. It's also using a topoisomerase inhibitor as the bomb, so to speak. It also seems to have similar activity. We've actually worked with both drugs at our institution and are impressed with both of them. We think both of them are really excellent drugs.
Maybe I'll just follow up on that too. In your talk, you mentioned genomic profiling.
Right.
So can you tell us a little bit about how you and maybe you as well, Terry, are using genomic profiling results to treat patients?
So everybody at our institution gets profiled. We have a variety of different trials that are being used in that situation. The one I think that's being probably most prominent across it's an international trial is something called BISCAY, which is combining checkpoint inhibition therapy with targeted agents. And there have been a variety of different targeted agents that have been involved in that trial, including FGFR, also a statin inhibitor. I think at least 6 or 7 different arms. Joe Kim, who's also at my institution, is leading an NCI-based study of a TSC1 inhibitor in those patients who are TSC1 mutated in bladder cancer. And again, that's about 10 to 20% of all bladder cancer patients. FGFR3 mutated, depending upon which assay you use, at about a quarter of patients overall. Seems to be higher in those patients who have non-muscle invasive disease. And you can pick your FGFR inhibitor du jour. There are numerous ones that are out there right now. There's Arlene Sifaraki presented the J&J data. There's one with Novartis that Monty led the trial for that was just published, I believe. Where was that? It was in
Cancer Discovery, yeah.
Your Cancer Discovery. He led that. He showed some great activity with that drug as well. So there are options, and I think molecular profiling is going to become the standard once these drugs are approved. HER2/neu is a target that's been overlooked in this disease. About a quarter of patients express it. Herceptin's really never shown great activity, but there are other drugs that are being evaluated in the situation. So from a disease that had nothing 5 years ago, we've really moved quickly forward.
What's the role of ramucirumab?
Oh, yeah, should have mentioned that. So ramucirumab is an is a anti-angiogenesis agent. We published data of a phase 3 trial. I got a name. Ram plus docetaxel, the range study, docetaxel compared to docetaxel alone in a second-line therapy. We showed an improvement in progression-free survival, doubling of the objective response rate of the combination compared to docetaxel. The survival data is now known. It will be presented at ESMO this fall. It was not a significant difference, but it was a trend towards overall improved survival. That's come out in a press release. So the real question is whether the FDA is going to approve this combination or not. There are discussions ongoing. Point out that the FDA did accept PFS as a primary endpoint for the study. So, and if OS was going in the right direction, they were going to approve it. But we'll see what the FDA says about the whole situation.
Got a question in the back?
I have a patient who's on Pembro for 1 year. I wonder about your duration of immunotherapy in your practice if the patient is responding.
We don't really know the answer. I mean, I showed the slide where it shows that a lot of patients can stop therapy and maintain their response. And just anecdotally, I've seen that in many patients. I have seen patients who relapsed, where the cancer started growing a year later. So there's not great guidance about when to stop. I think if the patient is okay coming in every 3 weeks for drug, then I keep going. And I either wait for toxicity or the patient to tell me. I don't know if you
Yeah, this would be a great cooperative group trial. Do a randomized study of, a fixed number of cycles of checkpoint versus continuous therapy in these patients. So my longest patient on atezolizumab from Vigor 210 just recently stopped treatment. It was 2.5 years. And he was complete response, and he developed adrenal insufficiency. We stopped him at this particular point. There's no right or wrong answer to this question. And I think what you have to do is, and this is, I think, the most important pharmacoeconomic question, because are we overtreating our patients, as has been pointed out before. But there's the fear that if you stop it, it's going to come back, and then these patients aren't going to respond. So again, it's an informed discussion. Experience with challenging patients with checkpoint after they've progressed has not really been that positive in this disease. But we've used that more towards the end of the road because we've got all these other trials that we have in play. So if we re-challenge them with either the same checkpoint or a different checkpoint, I generally haven't seen responses, but these are 3-4 years out, so it's hard to say.
All right, we have time for one more quick question.
Tom Reske here from one question. I was curious whether there's any literature on why those liver metastatic heavy patients do not respond, whether there was some sequencing and whether there's a role for local regional therapy. Then my second question is what your experience is on mixed histology. So if you see sarcoma or some sarcoma in the histology. And then my third question was neurotoxicity. Is there any literature on neurocognitive side effects, meaning, quote unquote, chemo brain? Is there any literature in the PD-L1s?
Or maybe tackling those questions in reverse. So the toxicity, there's not as much data about neurocognitive toxicity. I know fatigue is very common, and fatigue can sort of manifest in a lot of different ways. I think that's the hardest one to measure. We face that in prostate cancer, this question of neurocognitive decline with hormone therapy. And there are tools to measure it. I don't know that there's been clear, very strong data that checkpoint inhibitor therapy is associated with that sort of chemo brain that people notice when they're getting systemic chemo. I don't know if you've had experience.
I haven't really seen much of a difference in neurocognitive effects. I mean, I've seen fatigue, but it's not the same fatigue you see with some of the anti-androgens. It's very, very different.
And then for the first question about liver, the data, at least from what I sort of know and what I read, is that the microenvironment may be more immunosuppressive or sort of exclusionary, and that may portend why these tumors do worse. But I think there's still a lot to be sort of learned about that. We have given locally directed therapy, for example, for someone who has a big liver metastasis from bladder cancer, where we're worried about compromise of the biliary system, where we've had an interventional radiologist treat that with the hope of getting an abscopal response with immunotherapy as well. I can't say we have a huge number of patients where that's been successful, where we've really generated a dramatic response. But there are patients who do respond to checkpoint inhibitors with liver metastases. It's just less common. And then the alternative histologies, essentially any alternative histology is poor prognosis. There's no alternative histology that has a good prognosis in bladder cancer. And so if it's very neuroendocrine or small cell, like that first case, we'll use etoposide platinum, as a frontline therapy. If it's more sarcomatoid, it's really tough. I've given MVAC to those patients. I'm not sure that giving anthracycline. I mean, I think the anthracycline helps, but I'm not sure how much. I don't know if you have thoughts about the alternative histology.
Yeah, I mean, the one that people are thinking a lot about is the micropapillary variant, and does that respond differently to chemotherapy? I really haven't seen much of a difference in my experience. MD Anderson has got a different experience than the other people. They think it responds less well, if I remember correctly. The issue about the liver There is, and we see this with chemotherapy, we see this with checkpoint therapy, there is a population of patients who are almost anaplastic, who respond to absolutely nothing. And I think one of our goals is really identifying that group, and these patients do tend to have hepatic metastases. But there's no good molecular characterization. I think the theory about this immune sanctuary or this pharmacologic sanctuary is a reasonable one, but I don't have any other better answers for that at this point.
Thank you.
Go ahead and repeat the question.
Yeah, sure. Yeah, so for a patient who develops toxicity on a PD-1 inhibitor, is it reasonable to switch to a PD-L1 inhibitor? I mean, it's not been prospectively, looked at. The data, I showed you that meta-analysis seems to suggest that there's not much of a difference in toxicity. Personally, I think blocking the pathway is blocking the pathway, inhibiting PD-1 and PD-L1. So I think if you were going to do it, it would really depend on the degree of the initial upfront toxicity, how severe that was, alternative options. You could try switching. It's just that it's very much out on a limb, and you have to watch those patients really closely, be ready to act with steroids, et cetera.
We're coming really close to time. I had 30 seconds or less, wanted to summarize the bladder cancer trial portfolio we have at City of Hope. I see a lot of friends from the LA area over here. So, for cisplatin eligible patients, we have a trial of cisgem plus minus VX970, which is an ATR inhibitor. USC, a couple of other sites are running that too. We've paired up with USC on an up study for patients, actually, pembro plus Ephrin inhibitor, which is quite interesting. Great initial results. For patients who have failed PD-1 inhibition, we have cabozantinib with atezolizumab. We'll be talking about that a little bit today. And if you have profiled your patients, and if they have FGFR3 alterations, we have a trial of B701, which is an antibody. And if they're HER2 mutated, we have a trial of a drug called TAS0728, which is, covalent HER2 inhibitor in that setting. So.
Okay, great. Well, thanks for the discussion. Thanks for your excellent presentation. So we'll take a break. Let's make it about a 10-minute break so we can catch up a little bit, and then convene right around 9:50.